and I'm really excited to be hosting our third Rethink Real Talk. Sean and I were saying third's the charm. They've all been really charming and gone without a hitch. So hopefully that continues because we're really excited. It's my pleasure to introduce you to today's speakers. And we are so lucky to have not just one, but two experts joining us this evening on this topic. Dr. Ellen Greenblatt is head of Mount Sinai Hospital Division of Reproductive Sciences and the clinical director of Mount Sinai Fertility and IVF Unit in the Department of Obstetrics and Gynaecology. I'm going to stumble over that today. Dr. Greenblatt's main clinical and research interests focus on basically improving assisted reproductive technologies, ovulation induction in patients with polycystic ovarian syndrome and other causes of anovulation, and also fertility preservation. And then we also have Dr. Arielle Cantor, who's a Gynaecological Reproductive Endocrinology and Infertility Fellow at Mount Sinai Fertility. And Dr. Cantor aims to empower patients by guiding them in their decision-making throughout their fertility journey. And she has a particular interest in fertility preservation. And between the two of them, there were about at least a dozen other important credentials between them that I know we've been mentioning in the event promo. But again, just want to emphasize we're really lucky to have both of you here today. And I'm going to throw it over to you guys to take us through your presentation and answer all our questions from our community. Thank you.
Perfect.
Thank you, MJ. Thank you, Shauna.
Thank you. Okay. Okay, can everybody see my slides?
Not yet.
Not yet? Okay. Try that again.
There you go.
Okay. Okay, so thank you so much for this opportunity to be able to speak tonight. Dr. Greenblatt and myself are excited to be presenting on this topic. It's a topic that's quite important to both of us. And at our clinic, we have had patients who have had success with egg freezing, but also without freezing their eggs who have undergone treatment. So we're excited to present on this topic tonight. Before getting started, I just wanted to give a disclaimer that although we know that breast cancer can affect both men and women, for the purposes of this particular presentation, we'll be discussing fertility preservation in the context of people that have ovaries, although we do appreciate that breast cancer does occur in about 1% of men as well. So throughout this presentation, I'm going to go through some common questions that patients often have with respect to fertility preservation in general. So to start off, what are the reproductive challenges for young women undergoing gonadotoxic treatment? So chemotherapy, as well as pelvic and abdominal radiation and pelvic surgery or a combination, can have an impact on future fertility. And it really depends on the patient's age, the dose of radiation and where the radiation is targeted, as well as the specific chemotherapy drugs that the patient has. These are all things that can affect one's risk in their fertility. Chemotherapy can also have an effect on one's ovarian reserve. And when we're talking about ovarian reserve, this is a term we use very commonly in fertility to describe the amount of eggs that are left in one's ovaries. Further, with these treatments that patients are undergoing, the incidence of menopause can range anywhere from about 20 to 80%. And once again, this also depends on a woman's baseline ovarian reserve at the time of treatment. Additionally, if a woman is to undergo adjuvant endocrine therapy, this is not something that's compatible with pregnancy, and childbearing needs to be delayed while on this medication. So this can pose additional time delays, which can affect fertility as well. And we'll get into this in a little bit more detail throughout the presentation. Now, this is an important slide that's illustrating the fertility decline that occurs naturally over time, but is only accelerated with treatment. So in general, women are born with a fixed number of eggs. However, over time, there's a gradual depletion, which is more accelerated after age 35, but especially after age 40. And we know that chemotherapy or pelvic radiation can cause a sharper decline. Nowadays, there's also a trend of delaying pregnancy. So the proportion of women who develop breast cancer while pregnant or who want to become pregnant after treatment is increasing. So what exactly is fertility preservation? So these are techniques that are used to preserve the reproductive ability of individuals facing medical treatment that may lead to infertility. Now, when we're talking about different options for preserving natural fertility, these include either mature oocyte cryopreservation, which is egg freezing, embryo cryopreservation, which is freezing embryos, ovarian tissue cryopreservation, which is the freezing of ovarian tissue, or ovarian suppression with gonadotropin-releasing hormone analogues. And we'll go into these various options. So what exactly does the egg freezing process entail? So the first step is stimulating the ovaries to produce multiple eggs using injectable stimulation medications. These medications are given every day for about 1.5 weeks in order to develop follicles, which are the fluid-containing sacs that contain the eggs. For women with breast cancer, we also give a medication called letrozole in order to keep estrogen levels lower throughout the stimulation cycle. Several days into the stimulation, we then give another injectable medication to prevent ovulation of the eggs. And then finally, when the follicles reach a certain size, we give a trigger medication to stimulate release of the eggs for the actual retrieval. And throughout the process, blood tests and ultrasounds are done in order to monitor how someone is responding to these medications. The actual egg retrieval occurs with ultrasound guidance and sedation. And ultimately, we're removing the fluid from the follicles, which are then sent to the lab to look under the microscope to see the eggs. These eggs then get frozen with the eventual potential thawing of the eggs, fertilization, and embryo transfer in the future. So how long does this actual process take? So the entire process occurs over approximately 2 to 3 weeks. Initially, ovarian reserve testing, so the baseline assessment of one's potential for their ovaries is done in order to choose the appropriate protocol for stimulation as well as the correct dosing for medication. So this is done with a blood test as well as a pelvic ultrasound. We now know that fertility preservation can actually be started randomly in the menstrual cycle and doesn't have to be done at a specific time. And this does not seem to have a negative impact on the number of eggs that are retrieved. The sooner that one is referred to a fertility clinic to discuss this option, the more likely there is time to complete at least one cycle before treatment initiation. So what are some of the potential risks of egg freezing? So with respect to the actual medications, one might experience some bloating as the ovaries get stimulated. There might be some soreness at the site of the injection. There can also be some mild gastrointestinal side effects, headaches, or mood changes. Studies have shown that there's no evidence that's definitive linking fertility medications to breast or ovarian cancer, and we'll also get into this a little bit in more detail throughout the presentation. Ovarian hyperstimulation syndrome is a syndrome that's characterized by an overresponse to medications with development of a large number of follicles and very high hormone levels. Historically, the more severe form of this disease occurred in about 1 to 3% of people. However, with newer stimulation protocols that we have, we can lower this to about 1%. So it's not very common that we're seeing a severe form of this. But basically, there's fluid accumulation that can happen in the abdomen, which may need to be removed, and people could get quite sick. There are also procedures that, there are risks related to the procedure itself, including some discomfort despite the sedation that we give. There could be a risk of bleeding, infection, and risks associated with the sedation as well. So what is the chance of success with egg freezing? So the chance of successful pregnancy really depends on the age of a person when they undergo egg freezing and the number of eggs that are ultimately frozen. Ideally, we try to target anywhere from 8 to 20 mature eggs in order to ensure a good chance of pregnancy. And while we know that live birth is not a guarantee from this process, this is a good opportunity to try to have a child using one's own eggs. So what are the costs of an egg freezing cycle? This information is restricted to Ontario specifically, and the Ontario Fertility Program which was launched in December of 2015, covers egg freezing for fertility preservation. And in order to be eligible for a funded cycle, you need to meet all three of these criteria. So holding a valid Ontario health card, being diagnosed as having a condition where treatment is known to affect fertility or may lead to infertility, and have not yet received a funded fertility preservation cycle. So while the egg freezing cycle itself is covered, there are certain things that are not covered as part of the egg freezing cycle, which would include drugs or medications. However, if one has no drug coverage, there is the possibility of applying for compassionate medication coverage. The Ontario Fertility Program also does not cover the storage fee for the frozen eggs, nor the creation of embryos and embryo freezing. So now we're going to get into a few additional questions that were posed. Firstly, is fertility preservation safe? So fertility preservation and using fertility medications in women with breast cancer does appear to be safe with respect to breast cancer survival. As I mentioned with respect to the medications that are given throughout the stimulation, a medication called letrozole is often given concurrently in order to keep estrogen levels low throughout the stimulation. And there have been studies on this specific topic that have not shown a higher recurrence rate of breast cancer in women who decide to pursue fertility preservation. Another important question is pregnancy after breast cancer treatment safe? There have been numerous studies on this topic as well, and several studies have also shown that pregnancy itself does not appear to have a negative impact overall on breast cancer prognosis or overall survival. We know specifically with ER-negative breast cancer, this tends to have a higher risk of early recurrence. So this may influence recommendations as when it's safe to proceed with pregnancy itself. However, overall, pregnancy on its own does not appear to negatively impact overall prognosis in a patient who has previously had breast cancer. So when can I get pregnant after treatment? So this is really an individualized approach that needs to be taken. Ultimately, it's a discussion between a patient and their oncologist, and really one needs to take into account age, risk of recurrence, and adjuvant therapy as well. If someone's on endocrine therapy, one needs to consider a minimum recommendation of time that one needs to be on, which can change depending on one's underlying recurrence risk. But ultimately, the oncology team needs to be consulted with the fertility team in order to properly coordinate care, and decision of timing of pregnancy should be determined in consultation with your oncologist. So another important question that comes up is, can I stop my hormone therapy to get pregnant? And the safety of this is currently being studied in a large study that's currently undergoing called the POSITIVE study. And the goal of this particular study is to investigate if temporary interruption of endocrine therapy to allow pregnancy in ER-positive breast cancer patients is associated with a higher risk of breast cancer recurrence. So really, depending on what your underlying risk of recurrence is, that will dictate the duration of hormone therapy that would be acceptable by one's oncologist. And it's important to note as well that tamoxifen, as we discussed, is not compatible with pregnancy. And it's recommended an approximate 3-month washout period from tamoxifen prior to conceiving. We're going to speak a little bit about gonadotropin-releasing hormone analogues. And these are medications that can provide temporary ovarian suppression. They can be offered to reduce the likelihood of having ovarian failure after chemotherapy, and they can be used in conjunction with other fertility preservation techniques such as egg freezing. A desirable side effect of these medications is that it can help prevent heavy bleeding, especially when one's undergoing chemo. However, these medications do have side effects as well, including vasomotor symptoms or menopausal symptoms like hot flashes and night sweats, and they can also cause a loss of bone density, which is reversible once stopping these medications. So overall, these medications have been shown to protect ovarian function by reducing post-treatment amenorrhea or loss of a period and the risk of early menopause. However, in terms of them being used solely as a fertility preservation approach on their own, this is uncertain in terms of their effectiveness. So is fertility preservation my only option to get pregnant after treatment? So some might choose to not undergo fertility preservation. Some might not be able to undergo fertility preservation because of timing or other medical reasons. So what are other possible options? So there is still a possibility of natural conception for some. Some women may maintain some of their ovarian function after chemotherapy and retain their ability to conceive on their own. And this can be assessed through blood tests and ultrasound to see if this is a possible option. Other options for getting pregnant include egg donation, adoption, as well as child-free living. So there are options aside from fertility preservation. So shifting gears a little bit in terms of women at increased risk of hereditary cancers. So having a hereditary predisposition for breast cancer may also influence one's decision to pursue fertility preservation. Approximately 5% of breast cancers and 10 to 25% of ovarian cancers are hereditary. And in order to reduce gynecologic cancer risk in these patients, some women may opt for risk-reducing surgeries such as salpingo-oophorectomy, which is removal of the fallopian tubes and ovaries, or bilateral salpingectomy, which is removal of the fallopian tubes. So these particular surgeries can narrow one's fertility window because removal of the ovaries will result in infertility and premature menopause. So knowing that one is a hereditary predisposition can impact one's decision whether or not they want to undergo fertility preservation or not. Another question that comes up is, does having a BRCA gene mutation affect my fertility? So there have been numerous studies on this particular topic. Some studies suggest that BRCA carriers may have decreased ovarian reserve, may require a higher medication dose for stimulation, and have fewer eggs that are retrieved at IVF. Some other studies have also suggested the possibility of an earlier age of natural menopause in these women. However, these facts are quite controversial, as there have been other studies that report no differences in ovarian reserve or age of menopause in these women. Ultimately, if someone does have a BRCA gene mutation and they are having difficulty conceiving, they can see a fertility specialist in order to do baseline testing to see if there's an underlying concern. Ultimately, however, in this particular population, it's prudent not to delay pregnancy and potentially referral to a reproductive endocrinologist to discuss options for possible fertility preservation in the context of risk-reducing surgery, as well as the possibility of genetic testing of embryos if one wanted to undergo that process. So just to touch on that a little bit, is there a way to prevent transmission of high-risk genes such as BRCA? So this can be done through something called pre-implantation genetic testing for monogenic disorders, or PGTM. So this is a particular technology that can be used to test embryos for the presence of specific gene mutations. So embryos can be biopsied, and the samples of a few cells can be analyzed for a specific gene defect in question. So with respect to the inheritance pattern of BRCA, we would expect about 50% of the embryos in this context to be affected. Ultimately, based on the results from the genetics report, one can select embryos without a mutation to be transferred to the uterus. Unfortunately, this genetic testing is not something that's covered by insurance. There is also the possible option of doing prenatal testing in early pregnancy if the laboratory permits this. However, at this stage, one would then need to consider the possibility of termination of a pregnancy for a gene mutation, which may or may not cause a future cancer. So this would be a consideration in early pregnancy if one decided to go down that route. And that is the presentation.
Thank you. There are lots to absorb, as always, with all this information, but I was following along. We had a list of questions that had been submitted in advance, and quite a few got answered already. So thank you for all that great information. There are a few that maybe I'll start with asking, and then we'll throw it out to our community who's here today. But one that was submitted in advance is, if you have hormone positive cancer, does getting pregnant after cancer treatment increased your chance of recurrence if you are hormone positive?
So again, I know that Arielle kind of talked to that a bit. There are not a lot of studies, but the studies that are out there have been very reassuring to suggest that regardless of the underlying hormone status, that pregnancy does not seem to have an adverse effect on the overall prognosis of cancer. Very often, oncologists will recommend that women not conceive for a certain period of time after diagnosis, and that's usually because the incidence of recurrence is usually highest in the first 2 years. So that would be just a very, I'd say, a difficult situation to be in if you were pregnant with a recurrence. But overall, once people are given the okay, then it doesn't seem to alter prognosis. And that's one of the things that the PROMISE study, I think, will answer more definitively, because the initial studies have been, as I said, very supportive. But, the PROMISE study, which is currently ongoing, I think it might have been fully recruited. And I think they might just be doing, there's many years of follow-up. But I think that was going to be a really, really important study to answer that.
We're funding that, so I'm happy to hear that you think it's
important. No, I think that's a really, really important study.
In answering that question, you actually covered off a couple of others, because that was a when that came in, was that how long should I wait for active treatment, and just is there a good time frame if you're low ER?
I have to be honest, and I tend to defer those sorts of questions to the oncologist, because neither Dr. Cantor or I are oncologists. So, the prognosis and, risks and whether you're a very good prognosis, all these sorts of things, I really think is a discussion between the individual patient and their own oncologist.
I have a feeling the next question is also going to be sort of, it depends on the someone asked, how long does it typically take to get pregnant after starting the process?
Starting what process?
I'm assuming the process of trying to get pregnant after cancer.
Okay. Well, I think you have to I think you have to look at the general population, right? Like, what is the likelihood of anyone conceiving? I don't think breast cancer really alters that in many ways. So if someone has treatment relatively young, where, yes, everyone will get some decrease in the number of residual eggs in the ovary when they're given chemotherapy like cyclophosphamide, they're all going to have a drop. But the thing for ovarian reserve does not predict natural fertility, I guess is what I'm saying. So if your ovarian reserve is high, medium, or low, for whatever reason, because even in natural biology, there are women with low reserve, then the chance, assuming everything else is okay, sperm is okay, and there's no problem with fallopian tubes, if someone is having regular ovulatory cycles, like having a period, releasing an egg every month, then their chance of pregnancy is actually directly related to their age. And that's true for fertility. As women get older, two things happen. Their egg count decreases, because, as Dr. Cantor said, you're born with all the eggs you'll have, and you run out. What chemotherapy or pelvic radiation, which I know is not really part of the equation here, what it could do, it could artificially advance lower the numbers. But it shouldn't really alter the inherent egg quality. So if let's say you're 37, if you're 38 or 39 or whatever, your time to conception, time to getting pregnant will generally take longer than if you're 28. That's just biology. And, all couples, regardless of sort of having had cancer treatment, there are other factors that make it difficult for people to conceive. So just the general population, most studies would say like 12% of couples will have trouble conceiving. They will not have conceived within a year of trying. So that's why I'm saying, all things being equal, you know, you'd want to, I would say someone who has had treatment and maybe there's more pressure to conceive quickly, either because, you know, their window of opportunity might be shorter, or they're taking a hormone break, so they don't want to do that for years and years. I'd say we would probably want to see them if they haven't conceived in 6 months, because you want to make sure there are no other factors. But in general, for the average population, the pregnancy rate per single month of intercourse and trying to conceive is really only about, you know, 20% per month. It's a little higher when you're young and it's lower when you're older. And that has more to do with the fact of egg quality. As women get older, the quality of their eggs that they're ovulating or that we're collecting with IVF is lower. There are more chromosomal errors, and that is an age-related phenomenon.
Okay, thank you for that. I'm going to go to some of the questions that have been thrown into the Q&A box. And the first one is, what would happen if I were to get pregnant during chemotherapy?
So that's a really good question. So I think ultimately that would have to be a discussion, you know, with your oncologist for sure, with your obstetrician as well. It depends exactly at what stage of pregnancy you're in as well. And then I think it would also depend on, you know, the potential aggressivity of the breast.
Okay.
So I think, you know, depending on when your oncologist thinks you might need to start chemotherapy, you know, obviously chemotherapy while pregnant is not the best idea. So I think it would be, you know, some difficult conversations that would need to be had in terms of, you know, safety moving forward with the pregnancy.
Thank you. Here's another one. Are there any studies for PR and ER positive but HER2 negative stopping tamoxifen to get pregnant, and what do these studies show?
Well, I think that group is actually the most common group of reproductive age women, are usually hormone positive and HER2 negative. So I'd say that's sort of the majority. And again, I'd say most of the studies have been supportive, and the PROMISE study, which while we've been talking, I found out, yes, recruitment has been completed. They've recruited everyone they wanted to recruit as of January. So the rest of the next 8 years is going to be follow-up to find out, you know, if there's any altered outcome with what we call a fertility pause. So I don't think, you know, I wouldn't consider that particular group, receptor positive, HER2 negative, as being any different. If anything, that tends to be a good prognosis group in general.
Yeah, and kind of related to that, someone's asked when the preliminary information from that study will be available. I know, because we're funding it, that it's a long-term study. It's a 10-year study,
yes.
Which is going to give really great information to the next generation. But it's a long-term study. There might be updates along the way, but.
I think there will, yeah. My understanding is they think all the data will have been collected by 2028. But everyone who would be considered to enter the study has been recruited. You know, it does take a long time to follow things where there are long-term outcomes, and this is one of them. I think one very reassuring thing, and I've been in this field a long time, I have definitely seen a shift towards greater comfort in pregnancy after treatment, definitely from like 30 years ago, where everyone panicked because pregnancy is a hormone, you know, rich environment and all this sort of thing. So there's been a real shift in comfort. I think part of it is because just demographically, you know, we are delaying childbearing. So, you know, people are tending to have their families later. So we're seeing a larger number of women who, you know, the intersection of having cancer and not having completed your family is sort of larger, because, you know, 30 years ago, 40 years ago, most people had completed their family by the time they were 30. That's not the case anymore. Yeah. So this question comes up a lot more. But just the fact that this sort of study got, ethics approval, I think is very comforting, because any ethics board is very, very cautious about putting patients at risk. So I think that's one reassuring thing, just the fact that, it was felt that this is a study that could be safely done to really answer a very important question.
Thank you. A question that was submitted before the presentation, which I think is kind of relevant to what you just said about people becoming more comfortable with, young women getting pregnant after breast cancer. The question has come up, like, what are my options as an MBC patient? So I'm metastatic, but I'm in otherwise good health. I'm assuming like stability. And I'm sure that's a question that not every oncologist is comfortable facing or hearing from our metastatic community, but we do know it's one that they're interested in hearing about. What are the options if you're in ongoing treatment?
Mm-hmm. That's a challenge. Yeah. Do you want to do that, Arielle? Did you want to?
Yeah, I mean, I think that's a challenging thing to consider. And ultimately, these would be important conversations to have between the patient, the possible partner of the patient, the oncologist, and the fertility doctor as well, and whatever other treating members of the team. We know that people can actually live day to day quite well with metastatic breast cancer, although ultimately we know it's like a chronic disease as well. So these are considerations that need to be had. With regards to ultimate prognosis and depending on what type of medications that patient is on as well, if those are potentially compatible with a pregnancy as well, these are all things that need to be considered. Mm-hmm. So I don't think there's a straightforward answer in that particular situation. I think these are difficult questions that need to be taken from a multidisciplinary approach with respect to, the patient's, priorities and wishes and potential family members that are involved, as well as their treating team. So I think it's, possible case by case.
Thank you. Jumping or shifting gears, specific questions come up about, do I need to choose between egg freezing and egg embryos? Someone's heard that freezing your eggs can be a little bit more of a gamble when it comes to using them versus creating embryos and freezing those. Is there any better chance of going straight to creating embryos? Better chances of getting pregnant?
I actually think, like 10 years ago, the answer would have been a little bit different. I think the technology for cell and tissue freezing has really advanced so much. The Ontario Fertility Program only covers egg freezing. So if you choose to make embryos with a partner or sperm, like donor sperm, and then freeze the embryos, there is an added charge because the Ontario Fertility Program does not cover the embryology as part of the fertility preservation. They cover the stimulation, monitoring, egg retrieval, egg freezing. The only, every embryo starts as an egg, so there is attrition along the way, and that's true even in IVF with a fresh embryo transfer. So a woman going through IVF will, be monitored. We'll see follicles growing, and we hope we get an egg from each follicle. So, you're seeing follicles. You don't always get an egg from every follicle. Each egg you get may not be fully mature, so it might not fertilize. Fertilized eggs divide but can arrest. So there's attrition in any IVF cycle, from eggs to fertilized eggs, to dividing eggs, to a blastable implant. So that's happened. And whether, it's sort of pay me now or pay me later, if you freeze eggs, if you have X number of eggs, you're not going to have the same number of embryos, and that's true regardless. The only slight diminishment is that when you freeze eggs and then rethaw them, we expect the freeze-thaw recovery to be about 90%. Whereas if you use fresh eggs and you make embryos and then you freeze-thaw the embryo, that is about 98%. So you might lose an extra egg in there. But I think you have to be very, and that sounds kind of, I think freezing eggs gives you more reproductive freedom. if you freeze embryos, particularly with a partner, even if it's a stable partner, stuff happens in life. You know, half of marriages break up. And, you know, if you've frozen embryos and, you know, that relationship does not continue, and now, you know, you really need the biologic material that you froze before treatment, if that biologic material is tied up with somebody's sperm that is not going to be your co-parent, that could be very challenging. So, you know, I just consider frozen eggs just gives people more reproductive freedom, even if they're in a stable relationship. But it's not my decision. It's obviously, but I think they have to think of all those things. Yeah.
Great, thank you. We have someone who's raised their hand. So Shauna is going to let them in and they'll ask their question.
Sure. So Laura, I'm gonna throw it to you and let you ask your question. So here we go. Okay, you should be able to take it away, Laura.
Hi, thank you so much for doing this. This is so helpful. I know Ellen and Arielle, they're amazing, and thank you so much because I was one of the complicated situations. So I'm 38, I have very low AMH. I was able to freeze 2 eggs, and I guess, would you ever recommend surrogacy over carrying the child on your own? Just to potentially use your own eggs opposed to having a donor egg from the start. So that's my question, just because maybe it's better to just use a surrogate right from the beginning with the 2 eggs that I have.
Well, I think most of the problem if women get older is, like I said, related to quality and quantity of eggs. So, you know, you said your reserve was low, so you didn't get many eggs. And if those eggs were frozen at 38, then they're 38 quality. What uterus they go into is kind of irrelevant, to be perfectly honest. The reproductive aging process happens in the egg and not in the womb. So there have been women who have chosen to use a surrogate or a gestational carrier with eggs or embryos that they froze before treatment. They might do that because they're just not comfortable being pregnant, you know, while they're still on treatment, or they might not feel comfortable coming off hormone suppressing therapy to go through a pregnancy. So we have had women do that. But again, it really, the success relates to the egg, the age and the number of eggs that you're working with, whether they're fresh or frozen.
Okay, thank you.
Oh, you're welcome.
Thanks, Laura.
We've got so many questions for you guys. Thank you for typing in fast and furious. So I'm going to push through some of these. Let's see. Someone's a little risk adverse and wonders, what's the oldest I can be to have a decent chance to conceive post-cancer? And I think a related question, someone was asking, what do we consider relatively young? Because it's been mentioned that your chances are better when you're younger, so.
Okay, so yeah, age is a very touchy subject, and I'm very touchy myself. Reproductive aging is reproductive aging. So, for example, take you know, fertility treatment, like cancer treatment, out of it. I think, yes, if you started with a relatively low reserve, and chemotherapy has different effects on different people. Like, you could give the same treatment to 2 different women who are starting with a similar reserve, and one might end up with a bigger hit than someone else. Just like other side effects of chemo, nausea, hair loss, they're not like, it's not one size fits all. So if after treatment someone is truly in menopause, then obviously their own eggs will not work. But the chance of pregnancy, the chance of becoming pregnant decreases with age. the chance of miscarriages increase with age, and that all comes down to the fact that as eggs get older, this is the general population, as women get older, their egg quality diminishes. Eggs that are not competent either will not fertilize, or they fertilize and they won't attach, or they attach and they miscarry. So the chance in a given month for anyone conceiving, you know, it might be like 30% when you're in your late 20s, and it might be 15% when you're in your late 30s. That's sort of, there is a big difference. And then as women get older, there's a higher chance of pregnancy complications related to age, like hypertension, diabetes in pregnancy. You know, there's a slightly higher chance of chromosomal abnormalities, Down syndrome, and that sort of thing. And, you know, I always say, well, we're not lemmings, you know, so nothing happens, like you don't fall off a cliff where, you know, before the age of blah, 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 your pregnancy rate is such and such, and like 2 days later, it's something else. It is a continuum. So we do see declines in fertility anywhere from around the age of, you know, late 20s, more rapidly over the age of 35, more rapidly over 38, and much more rapidly over 41. So it's not a straight line. It's a bit of a, it gets steeper.
Thank you.
That was a non-answer for a question, but I think it's because biology itself is, it's not one size fits all. You know, some women in the general population, the average age of menopause is 51. But the normal distribution is 45 to 55. Now that's a big range. So clearly women who are going to inherently have menopause at 45 are going to have a lower reserve at a certain age than that same woman who is going to have menopause at 55. So there's a lot of inherent biologic change, variation.
Thank you. A question that's come in is, are miscarriages higher among women who've been treated with chemotherapy?
Arielle, do you feel comfortable?
Yes. Yeah. So we haven't really seen an increase in miscarriage rate in women who were previously treated with chemotherapy itself. If you're, you know, pregnant and on chemotherapy, that's another story. But with respect to having underwent chemotherapy previously and then being pregnant thereafter, we have not seen an increase in birth defects related to the chemotherapy.
Okay.
I will say, as a kind of baseline population risk, every pregnancy does have about a 3 to 5% risk of having a birth defect in pregnancy at baseline, regardless of any external factors. So every pregnancy does have an inherent risk. And as Dr. Greenblatt mentioned, you know, as women age, there's an increased risk of you know, genetic abnormalities in a pregnancy. But having undergone chemotherapy previously would not increase one's baseline risk of having a genetic abnormality in a current pregnancy.
Okay. Someone has asked if you could briefly discuss the PGTM process in terms of time frame, creating probes, etc.
Yeah, so in order to initiate the process, it's really important to liaise with our genetic counselor because they're going to be the ones speaking to the genetics company in terms of probe design. So one of the important factors is knowing the exact genetic mutation in question for the design of the actual probe for the genetic mutation. So we liaise with the genetic counselor and they reach out to the genetic company, number one, to make sure that the probe for the specific mutation is possible, and then to actually create the probe. So probe creation takes a few weeks. It can take up to 8 weeks potentially. It doesn't always take that long. It depends on the actual mutation in question and whether they're able to do that. And then usually once we have a probe, that's when we can, the patient can undergo the actual IVF process and stimulation for embryo creation. So the stimulation itself doesn't change. Ultimately, the embryos are created and then the embryos are grown to day 5 or day 6 or day 7 even. And then a biopsy is taken from the outer layer of the actual embryo. And it's only a few cells that are sent off to the genetics company to be matched with the actual probe. It's not the whole embryo that's sent off. And the process of getting the results from that testing takes a few weeks as well. It's usually 2 to 3 weeks before we actually get the report of the genetics from the embryos that were created.
And then once you know which embryos are sort of unaffected, and most women, while they're doing it, they'll also make sure that they're chromosomally balanced. Like you wouldn't want to put an embryo that doesn't have a BRCA mutation but has trisomy 21. So usually you'll want to make sure that it's chromosomally balanced and doesn't have the mutation, and then that's usually done the month after you have the report. So I guess that whole thing, you know, it's about 3 months, I guess.
Mhm.
Another question's come in that if your period returns regularly after chemo, is it kind of safe to assume you would have a chance to conceive naturally?
Probably.
Yeah.
I mean, if someone is having very often on chemo, during chemo, you know, period stop, that's quite common. But after chemo, if they recur and if they seem like they're ovulating, meaning they're very regular, you're getting some premenstrual symptoms, you have some cramping with your period, like that sounds like a regular ovulatory cycle.
Mhm.
You know, like I said, I wouldn't rely on natural conception for too long if you know you have an inherent maybe challenge, because there are other things too. Half of all infertility is related to male factor. So you don't want to keep going along and ignore, you know, doing a semen analysis, or making sure, you know, thyroid function's normal and your uterus is okay and your fallopian tubes are open and all the other things that we do like every day in a fertility clinic. But yeah, I would say, you know, if cycles sound ovulatory, like they're come within a day or two each month, usually associated with some, you know, premenstrual symptoms, breast tenderness, or, you know, backache. And the period is very reproducible. Usually when women is ovulating, there's some cramping on day 1 or 2. You know, if I get a history like that, I don't usually do a lot more testing to see if that person is ovulating.
Thank you. Someone was diagnosed with unexplained infertility 3 months prior to their breast cancer diagnosis and is curious, could that be related? Could having cancer in your body that's growing and active cause the infertility, is part of the question. And then the second part of that, is it even worth pursuing a future pregnancy? I know we've said it's safe after cancer treatment, but if you were already diagnosed with infertility issues.
Well, I mean, we see that not infrequently because, you know, I said 1 in 6 couples would be put into that infertility category. And when you do a workup for infertility, so you check for ovulation and you check to make sure fallopian tubes are open and you check sperm, you make sure there's no other factors, you know, 15 to 30% of couples will be unexplained. So you're talking about a pretty common phenomenon. And infertility by definition is like a year of unprotected intercourse without the ability to have a pregnancy. And unexplained infertility is really a diagnosis of exclusion. It means, you know, we're not that bright. We haven't found a cause. There's a cause, but it's probably at a more subtle level. So that's not uncommon, you know. I think they're just two common phenomenon. I don't think there's any cause and effect there. But, you know, that's kind of interesting. That person would say, well, great, now I could get my egg freezing done for free. You know, he might be someone that would be heading down the assisted technology route at some point anyhow. So, but I don't think there's any evidence that they're like cause and effect.
Okay. Another question, other than the obvious factor of time and age, is there any long-term adverse effects of tamoxifen on future fertility? So totally understanding that you're on this medication for 5 to 10 years, you're aging through that process. But once tamoxifen is completed, is there any long-term effect on fertility?
I don't really think so, as far as we know. One thing about tamoxifen you have to be a bit cautious is it can sometimes have a funny effect on the uterine lining, the endometrium. Tamoxifen is what we call an estrogen receptor antagonist. So it binds to estrogen receptors in the body, but it doesn't act like estrogen. So it sort of blocks the effects of estrogen. But it's actually what we call a mixed agonist-antagonist. And that means that at certain tissues, it seems to block the effect of estrogen, like breast. But at some other tissues, it almost acts like estrogen, and it seems to have that effect on the uterine lining. So there have been some women who, when they're on tamoxifen, they start getting irregular breakthrough bleeding. And if you biopsy the uterine lining, you could find some altered cells. I mean, I think that's manageable. So I don't think there's any long-term effects other than what you said, like time is passing. In fact, tamoxifen chemically is very, very, very similar to, and in fact used in Europe, very similar to a very common oral fertility pill we used to use called Clomid, or clomiphene citrate, which was the most common fertility pill we would use to get women to ovulate who don't ovulate. It's very similar structurally, and in Europe, some people would use tamoxifen for exactly that. So now when you're using it for ovulation induction, it's not taken every day, so it's taken and not at that dose. But some people would say, you know, we use it for fertility problems as well.
Okay. The next couple of questions are also a little bit related. So maybe I'll kind of outline these two questions. Someone's asked if, when having a frozen embryo transfer, does the age of the woman affect the chance of pregnancy, or is it the age at which the embryos were frozen that's more important? Or is it more like the age by the time you're doing the transfer? And then sort of similar, if you have low AMH and you were able to freeze some eggs, but only under 5, and you were between the ages of 38 to 40, is that a time where you would just recommend surrogacy over trying to bear the child yourself, just due to the number of eggs?
Arielle, you want to do that?
Yeah,
they are
so,
related. Yeah.
Mm-hmm.
Yeah.
So really when we're looking at the success of a pregnancy, and we're thinking about, is it the age of the egg creation with the embryo, or is it the uterus itself? Really the most important factor is really the age at which the eggs were retrieved. So really that specific timing is what's most important. So when the embryos were actually created, and when they're frozen in time. So if someone froze eggs or embryos at age 25 and then they're looking to get pregnant in their later 30s, really the success of pregnancy is related to the age at which the eggs or embryos were created, not so much the age of the uterus. We know that even, patients that are in menopause, we can still use their uterus to get pregnant. So really it's related to the actual age at the time that the eggs were frozen, which would predict success with respect to pregnancy, in terms of, number of eggs that were potentially retrieved and also the quality of those eggs. So once they're frozen in time.
Okay. Dr. Greenblatt, did you want to chime in? Or you're...
No, I totally agree.
Okay.
I totally agree. And it did relate to a previous question where someone said, I only have 2 eggs. Should I use a carrier? And I'd say it's not the carrier issue. It's like the age when the eggs were produced or frozen, and that's true for IVF where people are doing fresh embryo transfer too.
Okay. The next question that I'd love to throw out there, a question about this came in before the session, but I see someone's asked about this in a slightly different way. I don't know if it's the same woman, but with the genetic mutation of TP53, is it possible to get pregnant naturally and test the embryo? A little bit of further context, I'm 31, just diagnosed with stage 1 breast cancer. I have a genetic mutation of TP53. Is IVF the only way to have a baby and ensure that I do not pass on the TP53 mutation, or is it possible to test the embryo with naturally getting pregnant?
Mm-hmm.
You can't test the embryo because, when you conceive naturally, the embryo is in the uterus, and we can't get it out. So the only thing that would be possible is to conceive naturally and then to test the pregnancy per se through you know, a sample like amniocentesis or a sample of the placental tissue to see if that pregnancy is affected, but then you're faced with terminating the pregnancy. If it's affected, you don't want to pass it on. So there's no way to test an embryo before implantation except for creating it outside the body with IVF.
Okay. I know you're not geneticists, but
We're pretty close. We're pretty close.
You're close. You're close. I don't know if it's the same person, but they've asked, is like, what is the percentage of passing on this genetic mutation, this TP53?
Now I'd have to go to Google here. I think it's autosomal dominant. Anything that's autosomal dominant, I'm not a geneticist, but anything that's autosomal dominant means that the chance of passing it on is 50-50.
Okay. Kind of related to this question, which is, I think sensitive, is just, you had mentioned considerations around possible termination of pregnancy for a gene mutation, which may or may not cause a future cancer, and just a little bit further explanation of that, what you meant by that.
Yeah, so for example, with BRCA, the mutation specifically, so women are at increased risk of breast and ovarian cancer throughout their lifetime, but there are women that are BRCA positive that won't develop a malignancy in their lifetime as well. So, you know, while the risk of breast and ovarian cancer is significantly increased, and it over time the risk continues to go up, there is also the possibility of not developing a malignancy as well. So, you know, it's something to think about whether or not, if you were pregnant, if that was a reason you might want to consider a termination or not. Of course, it's always a more difficult decision to make once you're actually pregnant than preconception. So these are things to consider, whether or not, you know, genetic testing is something that is an option for you or not. There are patients that know they have a hereditary predisposition and decide not to do any genetic testing at all and just let the fate of the pregnancy determine, you know, the future. But for some patients, they might consider the option of doing the genetic testing early on, either preconception or an early pregnancy, but then there's some difficult decisions that may need to be made depending on, you know, how you're feeling.
Thank you.
I mean, that's, I think that's where ethics, you know, meets reproductive technology. And I think that's a very individual sort of discussion to have.
Mm-hmm. Yeah. Thank you. Another question: how long should someone try to conceive naturally before deciding to use a frozen embryo? Now, I know you mentioned trying for a year and nothing happens, then you're considered maybe infertile, but what's the situation post-cancer?
I think it again has to be individualized by a couple of things. One is, how old is that person when they're trying? Because as women get older, just naturally it will take them longer to conceive. Are there any other fertility factors that might be making it more difficult? So that's why I said I don't think you'd want to try for too long without making sure that the whole fertility spectrum has been investigated. And then the third thing is, you know, are you on a tamoxifen window? So very often, you know, oncologists say, well, you know, we feel it's safe for you to be off for X period of time. Now, if that X period of time is a year, then, you know, and pregnancy is 9 months, then you have to get on it pretty quickly. So I think it has to be individualized based on all the, you know, all the factors involved. It depends on how many embryos you have. You know, if you have a lot of embryos, you might say, well, you know, why don't I just use them, type of thing. So I don't think there's, you know, there's one answer for everyone that might be asking that.
Okay, thank you. Another question: is there a risk of remaining on goserelin long-term from a fertility standpoint? Goserelin?
Yeah. Again, yeah, goserelin or Zoladex or any of the like depot GnRH agonists that sometimes are used to try to decrease estrogen in the body and hormone sensitive tumors. Again, I think they're reversible, meaning that once it leaves your body, your cycles should return. Now, there's a few caveats to that. Your cycles will only return if you have enough ovarian reserve that you haven't become menopausal in the interim. The other thing is time, right? So you mentioned before, if you're on it for a long time, if you go on it at 35 and you come off it at 38 or whatever, I'm picking numbers out of the air, your fertility will have been affected by that time period. And the third thing is sometimes I do find people who have been on depot forms of GnRH agonists, sometimes it takes a long time for it to totally leave their body. So if you've only had a couple of shots, you know, you've been on an agonist for 6 months, usually we expect your period to come back within about 8 weeks. But I have had women who've been on agonists for like 2 years, and then I've seen it take up to a year for it to come off and to actually get their cycles to come back.
You answered a question that was in the queue right there.
Oh, there you go.
Yeah, there's lots of questions here. Another one is, if you have a frozen embryo, do you need to have resumption of your period in order to use the embryo?
Arielle?
Show a sign of stability.
Yeah, so not necessarily. So, you know, we have women that are menopausal that we're doing, you know, endometrial preparations for to prepare them for a frozen embryo transfer. So we have different protocols to prepare the uterus in order to allow you know, a suitable environment for an embryo. So you don't necessarily need to get a period before doing so.
Okay. Oh yeah, I see 3 questions here that are all about genetic testing on embryos. So I'll just try to kind of maybe combine them, or just give you all 3 of them. So can genetic testing be done on frozen embryos before the transfer? Another related question, my partner and I completed genetic testing using probes on an embryo, grade A. However, we were unable to test other embryos due to their grade. Wondering if there are any other options available for testing these embryos for the BRCA gene. So it sounds like some could be tested and some couldn't. Is there another option? And then actually answer that one, and then I'll give you the next question.
I mean, if you say couldn't be tested, it makes me think that the embryo was not well enough developed. So an embryo has, like, remember I said there's attrition along the way, like things stop. Not all eggs will end up being embryos that look beautiful. And usually we consider an embryo as being transferable, freezable, or biopsiable if it's attained a certain level of development. So if an embryo has arrested or fragmented, or then we wouldn't consider it quality for either transfer, freezing, or biopsy. So I think once you're there, you're there. Like, again, I think, you know, you have to have that discussion with the fertility clinic and doctor doing it, because I'm trying to read a little bit between the lines there. Normally an embryo would not be frozen if it wasn't even good enough quality for biopsy. So that's why it's hard for me to really comment on that. And I can't remember what the other question was.
The other one was, can you test the frozen embryo before transfer? Can you do genetic testing?
Well, you would have to refreeze it, because the genetic testing takes a few weeks. So let's say you froze an embryo and you didn't know you had BRCA at the time, which happens, right? So someone might be diagnosed and they're referred for freezing, and they freeze. That's why I'd rather freeze eggs, but let's say they chose to freeze embryos. And then over the course of the while, they also found out that they have a BRCA mutation. And they didn't know that, because it takes a while for that to come back. Then when they go to use those embryos, if they did want to test them, they'd have to be thawed, biopsied, refrozen until we got the information back, and then decide which were transferable. Another good reason to freeze eggs only, because, yeah, you wouldn't be adding one more freeze thaw in there.
So someone has 2 genetically tested embryos frozen at age 35. They are ER/PR positive, HER2 negative. And after 2 years of tamoxifen and a 3-month washout period, would it be better to implant both embryos at the same time or do them separately? So just given this person's age, they're just wondering, do I just go with 2?
Have they been tested?
Says, say you have 2 genetically tested embryos. So
Okay.
yes, they have.
So if they're genetically tested, to me, it probably means they've been tested for both things. Like they've been tested for the BRCA mutation and they don't carry it. And usually they'll also test to make sure they're chromosomally normal, because once you're testing, you might, like I said, why put in an embryo that might be Down syndrome? We never put in more than 1 at a time when the embryo is chromosomally normal. It doesn't matter how old you are when you made it, because it has such a high implantation rate, and twins is high risk. Like, why would you put yourself at risk for twins? So if an embryo is chromosomally, because twins could deliver early and not be viable, and it's a complicated pregnancy, it's considered high risk. So if you have an embryo, first of all, if you're young, it should be good. If it's chromosomally normal, it takes the aging effect out of it. So a chromosomally normal embryo from a 40-year-old versus a 30-year-old, because it's chromosomally normal, that's corrected for the aging effect. We would only recommend 1 at a time.
Okay, well, it's now 10 after 8. I think maybe a couple more questions. There's one here that is asking, is there a scenario you can imagine where it wouldn't be advisable to get pregnant after treatment? So if your risk of recurrence is very high and you're hormone positive, and then kind of related, doesn't the risk of recurrence decrease with time from diagnosis? So does that mean as more time passes, it would be safer to get pregnant? Although hard because you're
I always say that's a discussion between you and your oncologist. I never tell people when it's safe, because I'm not an oncologist and I don't know their entire story and I don't know their own individual prognosis. And everyone's different, right? In general, the longer people, the longer you go in remission, the more likely you won't recur. That's a generality. In general, usually an oncologist, even in a good prognosis patient, would prefer you wait 2 years, because that's the period of the highest recurrence rate. It doesn't go away at that time. It just, the longer you go, the better your prognosis. So it's always a discussion. Life is a discussion, a series of decisions. Lots of things have to be balanced into that. And, I think that's one of them. Certainly, I did say, I have had patients who really want to get on with their family, but, for whatever reasons, maybe it's too early, and they might have someone carry for them for that first pregnancy, like use a gestational carrier to have a baby while they're still maybe not feeling it's an ideal time.
Okay, thank you. And I guess this could be the last question. Can you provide resources for surrogacy in BC? And this is from someone who has frozen embryos but can no longer have a baby due to the risk that they've discussed with their oncologist. So they've had those conversations, and
there's quite a few IVF clinics in BC, and I think you'd meet with one of those.
Okay.
Yeah.
Great. I'm just quickly going through. I think that we answered a lot of questions. Thank you to both of you for being here, and thank you to everyone for being a part of this, and thank you for all your questions. We will definitely, what we like to do is kind of mine those chats afterwards, and we get great ideas for content, and it's really helpful for us to know just what everyone's, concerns are and questions are, because that's how we can continue to build our programming. So thank you. And just, I hope everyone has a great night. Thanks again.
Our pleasure. Thank you for having us.
Take care.
Thank you so much.
Thank you, everyone.
Thank you.